Thanks very much. It's an honor to be here. Thanks very much to the senators and all the staffs that arranged this. That was a terrific talk. That was discovery-oriented research. It was designed to educate, it was designed to inform you. This talk will not educate you. There is nothing new in my talk, which is my real problem with this whole hearing. So much of this we know. This talk is designed, hopefully, to motivate you and motivate the Congress of the United States and the public in the United States. Because, as Nora says, we know not enough, but so much. We know so many things that we can and should do. In fact, let me start with the end of this talk, in case you fall asleep, okay? We've been thinking about addiction the wrong way. We thought it was entirely a criminal justice issue. We thought it was entirely a problem of character development. And it wasn't anybody's fault. We didn't have the science. Now we have the science. Yes, there's an important role for criminal justice, but it is fundamentally a brain disease. And Nora showed that beautifully, okay? It needs to be treated that way. It needs to be thought of and prevented that way. And here's the one that bugs me the most. Because we know this, because we can, and I'm going to show you 3 simple examples, we should. We should. We've got to, because people are dying over this, okay? All right. You can imagine, if you ever heard me talk, that you're going to see this pyramid. Well, here it is. This is the picture of what substance use looks like in the United States of America among adults, okay? It's a pyramid. Most people in the United States do not use drugs, and that's, I guess we don't have a pointer, do we? Anyway, down the bottom of the pyramid, that's where there's very little or no drug use, okay? And that's the majority. As you go up that severity pyramid, right there where that wavy dotted line is where substance use disorders start. That's not addiction. That's when you're drinking too much or using too often for your health. And there's a lot of people who are doing that. In diabetes, that's called pre-diabetes. That's a diagnosis. That's a treatable condition. That's a reimbursable condition in diabetes. It's smart for that, because that's where you can intervene early and prevent escalation to the next level. Now, when you cross that bright yellow line there, you are in Charlie Sheen territory, okay? You are addicted. You are with 23 to 25 million Americans who meet diagnostic criteria of addiction. As Nora just said, you probably can't see that little pinnacle at the back. That's how many are getting treatment. And the only thing we've ever, thing we've ever talked about is addiction, and that's been a mistake too. It's been a mistake because we can see it coming, as Nora put it down. You can see it in your kids. You can see it in your students. You can see it in your patients. Can't we finally do something about it? Oh yeah, wise guy, what? Well, how about if we had real evidence-based prevention for the people who have not yet started to use? We have early intervention. If you think these are new thoughts, folks, you have really not been around. These are not new thoughts, okay? Early intervention for people who have begun to use but have not yet crossed into addiction, and comprehensive primary and specialty care treatment for this disease, just like it's received for every other chronic illness. Okay, all right, I get that, but give me some examples. Glad you asked. Let's talk about some prevention. And there are many people in this room who know a lot more about this than me. Let's talk about the science first. As Nora said very nicely, we now know addiction has an at-risk period. By the way, it's not just addiction. It's that period when adolescence, where the brain is still developing. You're not just at risk for addiction. You're at risk for drug-related harms, dropping out of school, unintended pregnancies, injuries, accidents, et cetera, et cetera. So So that's where you ought to focus your energy. And think about it. If I said, we now know that cancer has an at-risk period. It doesn't, but if we did, and we said it's between the ages of 10 to 15, do you think the American public, and do you think the Congress of the United States would have the chutzpah to stand up and say, I demand that my 10 to 15, for that 15-year period, we do something and do it science-based? I think they would. Here's another thing. Substance use is among the things that harm our adolescents. It's not the only thing, but when you turn over any of those rocks, delinquency, early dropout, inability to compete in following school, all of them, you have the same kind of antecedents. And again, Nora nicely showed them. It's all work done by the National Institute on Drug Abuse. Here's the other thing. If you combine interventions, remember that slide that she showed with all the risk factors? Suppose you did something that was able to combine the effects that a justice system could do, that the business community could do, that the schools could do, that the parents could do. Suppose you could do that, you would get 1 + 1 + 1 = 6 or 7 or 8. Okay? It was, put differently, it would be smart to do. Here's an example of what prevention looks like in most places today. On the left here, I have just some of the areas that, of the forces in society that influence kids as they go from 10 years old to 21 years of age. So what do you have here? Looks to me like there's the usual school anti-drug program. Drugs are bad, kids. We clear about that? Okay, box checked. Notice something. It does not affect the entire period at which you're at risk. This is a period where you're continuously at risk, just like if you were at risk for sun poisoning. You wouldn't just have a lecture with your kid and say, you know, you really ought to use sunblock. Are we clear? All right. You would make sure the kid had sunblock every time he went out in the sun. Well, there's no evidence here that things are going across the entire period of risk. The law enforcement community apparently has some kind of, I don't know, threat surveillance or something, and they've done that for, and they're focusing on older adolescents. But there aren't any environmental policies, parents aren't in the game, et cetera. In other words, it's a typical community, unfortunately. Well, here's what it could look like, and I'm going to show you, point out to you examples of places that are already doing this. This is what we used to call a prevention-prepared community. There are other names. I'll give them in a minute. But the point is, all of these environmental forces are in play. The environmental policies like reduction of liquor outlets, no tobacco devices. Law enforcement is providing information and surveillance. Parents in this community have learned what to do and when to do it, and it's different. Notice in schools there's prevention education, not just once, every year, and it's integrated into the curriculum. That's the kind of thing that not only should be done, it can be done, and it's being done. When you do it, there are people here in this room from CADCA, communities that care and prosper are two others. One I'm particularly fond of is in Alberta. Now, they've got the gumption. They've got the ability to harness their political forces, business forces, educational forces, and they've transformed the way they approach not just health care, but education. They use the ACEs score, and they've gone on the alert to make sure that parents understand that they are responsible for building brain architecture and reducing stress in their kids. And that through that, they will reduce, the grand bet is that they will reduce costs to the province of Alberta. It's been implemented, it already has. In studies, done by NIDA, done by SAMHSA, done by many groups, you see 40 to 60% less substance use and fewer substance-related consequences than in matched comparison communities. That is not a subtle effect. And let me remind you, this is during the period of adolescence. So it simply builds. And that means, of course, dollars. You've got to be an idiot not to realize just how much money can be saved, not just over the long term, immediately by this kind of work. Point. This is science-based. It follows directly from what we've known about the science, but most importantly, it is being done by many communities. It can be done by all of them. Congress, the voting public, business has to come together now. It's time to stop screwing around and start putting some of these things into effect. All right, well, that's prevention. How about when prevention doesn't work and substance use has started? Maybe there's been a drunk driving incident, whatever. This is not hard to do. And again, I wish I could take credit for this. There's nothing new here. You can identify harmful use, not addiction, harmful use. Use that is going to interfere with a kid's development, his health, and his relationships. You can do it with 2 to 3 questions. You can do it in a healthcare setting, and indeed you should, because 20 to 50% of the cases that a doctor will see in their day have a substance use problem that is compromising, increasing the costs of the care that is being delivered. It is, put differently, it is in the interests, the direct interests of the healthcare field to do this work. If you're in the ER department or a trauma center, it's way up. It's like 60 to 70% of cases. And you can do something about it. 5 to 10 minutes, not just of chatter, but of sensible, motivational interviewing and continued monitoring improves the quality of the care that you're delivering for the other condition, and it saves dollars. Washington State saved $8 million in Medicaid funds in 1 year. In a study they did in ER departments, they did screening and brief interventions where they, for everybody who came into the 9 hospital ER departments, they all got screened for substance use problem. For half of them, that screening was followed by a 5 to 10 minute brief intervention. Let me just stop there. 5 to 10 minutes of a brief intervention. And what you're looking at there is the next year utilization of the 2 groups. And that saved $4,000 per member per year. That is a great deal of money. The point is, number 1, this follows directly from what we know about the science. Number 2, you can do it. It's not hard. And 3, people are doing it and they're saving money when they do it. I don't know what's the matter here. All right, what about treatment? This may be a little bit new to you. I'm not going to go into the many kinds of treatment that we have. What I'm going to go into, it hasn't been enough. We've got many new medications. We've got lots of behavioral therapies. We've got all kinds of community interventions. We now have the willingness on the part of the criminal justice system to work with treatment. But it still hasn't been enough. Enough for what? Enough for how to find good care. I am not just a researcher, I am a parent of a kid. Happily, I am an expert in addiction treatment. I devoted my entire life to it, okay? So when my kid got addicted, I certainly should have known where to go get help for my kid, right? Not only that, I had 10 other experts in the field that I worked with. Well, I didn't know. I didn't know where to go. There was nothing. Now, if I wanted to buy a refrigerator, I knew how to buy a refrigerator. I would go to Consumer Reports, and there would be a list of quality features, a list of refrigerators, nice comparative, objective information. Well, we ain't got none of those. Well, thanks to NIDA and thanks to PCORI, the group at Treatment Research Institute, John Cacciola and Kathy Myers, building on prior work from Drug Strategies and Matteo Falco's group, said, why don't we do exactly the same thing for addiction treatment? Why don't we just give that information out? It's the kind of thing that society understands and uses when they want to buy a car, when they want to buy a refrigerator, whatever. That's what they use. And it has two important effects. The first effect is for Mr. and Mrs. Jones, right then, right there. Which of the available treatment programs should Johnny go to? That will help direct their decision, just as it does when you buy a refrigerator. But the second effect is even more important. It will inform and direct the marketplace. We have better cars, better refrigerators, better things, in great part, because we have informed consumers who know what to shop for. Did you ever shop for addiction treatment? You would imagine that the quality features are the thread count in the sheets and the view out the window. Well, those aren't related to anything that has to do with effectiveness. But that's what's presented. Well, there's an example of, right out of Consumer Reports, cell phone service. And notice what you have there. You have the purveyors down the left-hand column and the quality domains and the features across the top. You've all seen it. It can't be strange to you. And you will notice that some are better than others. If you got red-filled dots, you have a better quality feature. And I'm going to go slow here because this is really tough. More filled-in red dots, better quality, okay? I don't get your point. Well, suppose we did the same thing with treatment programs. I'm going to show you actual data here. We'll put the programs along the top. These are actual programs in the city of Philadelphia. And the quality dimensions will be down the left-hand side. And again, this comes directly from the treatment programs that were willing to allow us to measure quality. And I'm not going to show you the data quite yet, but you will see the domains here along the left-hand column. These are not strange things. Assessment, attention and mental health, comprehensive integrated care, family involvement. There's no esoterica here, continuing care, et cetera. And along the top, we have A, B, C, D, E, about 10 treatment programs. Now, you're going to see red, yellow, and green dots. If it's green, that's a good thing, folks. It means that the quality elements are there. They were seen, and they're there, and they're adequate. If it's yellow, it means that they're in development, and if it's red, they ain't there, okay? Here's the data. That's sort of interesting. Yeah, it is. Now, if you want to send your kid to program A, which, by the way, happens to be an outpatient program, you can see that you got a lot of green there. That is, I'm going to tell you where the criteria come from in a minute, but there's a lot of green and yellow. Nobody's doing program evaluation. It's very hard to do. But look at the rest. Look at the rest. They're terrible, to be perfectly blunt. They're terrible. They're lacking in the most fundamental of the qualities that you would want your kid to have in treatment. Now, why do I say that? Because I want to get these programs. I've got a thing against programs. No, wrong. They're doing the very best they can with the meager, antiquated, badly thought out infrastructure and financing system that they now have to put up with. They could do better, and it is our earnest hope that with this kind of information and public demand for higher quality, public understanding of what higher quality is, and demand for it, that you're going to get that. Michael said it. That's why AIDS has made strides, and the addiction field has still to make those strides. All right, now how's this go? Where'd you get these quality dimensions? Are these just things you guys ginned up? No. We used the same kinds of strategy that Consumer Report did. And my public thanks to Consumer Report who helped us with this. We did an empirical study of all the dimensions of care that had been studied, and we used the same criteria that the Food and Drug Administration used when they evaluate medications or new medical devices. 2 randomized controlled trials or a large clinical field trial. And these are all things done during the course of treatment that have been associated in research with better longer-term outcomes. And how much does this cost, and how long does it take, and all that? The thing that was contributed here by John Cassiola and Kathy Myers is they standardized the scoring procedure. They standardized the way the data are collected, so anybody can do this. A German Shepherd could do this and get the same answer as Tom McLellan, okay? It is designed for use by existing personnel who currently work in state facilities. Every single state has a group of people who go out and do inspections for licensing or regulatory. This will not add additional costs. This is consonant with the work they're already doing, and indeed is related to better outcomes. Okay? Oops, sorry. I do not have results because this has been a bear to get acceptance, frankly. But it's being implemented now by 2 states, and there are other states that are showing interest. So, you made it through to the end. And the end is very simple. It's possible, thanks to the work that NIDA has been doing, NIAAA and SAMHSA and others, we've got a lot of the science we need, certainly enough to prevent far more cases of abuse and addiction. The way to do it, focus on adolescents, use empirical methods, try to deliver at a community level. That's the most cost-effective. We have enough information to identify, intervene early, curb emerging use. It's not hard. It can be done, and it's probably not worth doing everywhere, you know, in every bus stop in the country, but in judiciary, in schools, and healthcare, it's certainly worthwhile because you can take constructive action. And finally, we know how to treat, Nora said the same thing, treat serious cases of addiction. We can do better than we have. We need the infrastructure, we need the financing, and we need the public demand to make it such. And I'll end with this personal note. And I love this forum and the attention to this. But I am an old dog in this field, and I see a lot of the same faces. And I'm saying the same words. You haven't heard a hell of a lot of new words out of me. And I'm fed up. I am not just a researcher. As I say, I'm a person who has 1 child actively in addiction, and I lost a 2nd child. These issues kill people. This is not FCC bandwidth regulation. This is a life and death issue, and it's time to cut the crap and start implementing some of these things. And I sincerely hope that this work will lead to that kind of effort, because if not, shame on us. Okay, thank you.